scarring on the lungs, and pressure in my heart, an overview of lung disease in systemic sclerosis. My name is Lori and I live in Halifax, Nova Scotia. I have interstitial lung disease caused by my scleroderma, and I'm really looking forward to hearing our speaker today. We would like to thank our sponsors for making our webinar series possible: the Government of Canada's Emergency Community Support Fund and Community Foundation of Nova Scotia. Scleroderma Atlantic in no way endorses any drugs or treatments shared within this webinar. It is recommended that all drugs and treatments be discussed with the listener's physician for proper evaluation and treatment. Okay, we will have time at the end of this webinar for questions. You'll be able to ask your questions using the Q&A icon on your computer or on your tablet. Our speaker for today's webinar is Dr. Gokul Vidyasankar. Dr. Vidyasankar is an academic respirologist with the Faculty of Medicine at Memorial University and is based at the Health Sciences Center in St. John's, Newfoundland. After finishing his internal medicine training at Memorial University, he completed a clinical fellowship in respirology at the University of Ottawa. Clinical areas of focus include interstitial lung disease and cystic fibrosis. Dr. Vidyasankar is also involved in several community initiatives dedicated to improving care of patients with COPD and interstitial lung disease, and currently serves on the board of directors for the Canadian Pulmonary Fibrosis Foundation. Welcome, Dr. Vidyasankar.
All right, thank you, everyone. So hopefully we'll have some time at the end, but I'm very happy to be a part of this session today. I'd love to talk about this topic. It's near and dear to my heart, and hopefully by the end of it, you'll have a better sense of how our lungs and our interaction between the lungs and the heart work, and an overview of interstitial lung disease and pulmonary hypertension as it applies to systemic sclerosis. Okay. So in terms of disclosures, I have served on advisory boards and I've received speaker fees from the following pharmaceutical companies. So our goals today are to review the basic anatomy and function of the lungs and the pulmonary circulation, meaning the lung circulation, the impact of interstitial lung disease or ILD on breathing, review the management of scleroderma-associated ILD, and then discuss some of the fundamentals of pulmonary hypertension, which can also be seen in systemic sclerosis or scleroderma. So just briefly, what do the lungs do? I mean, we all know that the lungs are important, but what is the main purpose, and why is it such a struggle when they don't work well? Okay, so what do the lungs do? When someone takes a deep breath in, as you can see with the arrows, the chest wall expands, the lungs get opened up, and that's when the air gets drawn in. When someone blows out, that's when you use your muscles in your chest and your belly to blow out the air, and that's when the chest closes, the chest deflates, and the air goes out. You can click again. So when you take a deep breath in, you take in oxygen. Next. And when you blow out carbon dioxide, which is the body's waste product that gets expelled through the lungs. Next, please. And the tool that I think that is very similar to the lungs is this set of bellows here. So if you look at this is pretty old-fashioned. This is used to fan the flames in a fireplace to try to build up your fire so you can roast your marshmallows. When you open up those handles, you're drawing air in, which is very similar to what happens when the chest wall expands. When you close that handles, you're pushing the air out, which is more of an active process. And once again, that's what the lungs do when you breathe the air out. Next, please. Just a few basic definitions. So the total lung capacity is a term that we use to describe the total amount of air that your lungs can hold. Now, this is air that includes what you're able to breathe in and out, but it also includes some air that stays in your lungs even when you blow all of that air out. The next definition, which is important, is something called the forced vital capacity, so the FVC. Now, this is the total amount of air that you can voluntarily push out of your lungs. So it's basically the amount of air that's functional for you that you're able to use for your breathing. The diffusion capacity is the ability of your lungs to exchange oxygen and carbon dioxide. Once again, that is essentially the primary purpose of the lungs. Next. So what is pulmonary fibrosis? It means, simply put, pulmonary means lungs, fibrosis means scarring. So it's really just scarring and or inflammation of the lungs. And one of the big distinctions I think is important to put forth is that it's not an airway disease. Next, please. So asthma, COPD, cystic fibrosis, these are all airway diseases, meaning that there's a problem with the tubes. And typically it's a problem with getting the air out. So you can breathe in, but it's harder to breathe out. That's a phenomenon called obstruction. And usually these three are classified as obstructive lung disease. So that's a problem with the tubes. Next. Next, please. So pulmonary fibrosis is not a problem with the tubes. In fact, the airways are sometimes kept open, and they're kept open for longer than they would be with airway disease. So pulmonary fibrosis is a problem with the air spaces itself. So if you think about your lungs as a set of tubes and balloons, pulmonary fibrosis is a problem with the balloons itself. Next, please. And pulmonary fibrosis, once again, a big part of it, but inflammation can also be present. So it's usually a spectrum between fibrosis and inflammation, often both. Next, please. So the consequences. So if you think about these balloons, and normally they're supposed to open and close nice and smoothly without too much effort. With pulmonary fibrosis, you're getting those lungs and those balloons being scarred down, so that you can almost think of it as a dry balloon. So with stiffer lungs, there's more effort to move them. So in order to open and close them, you have to work harder. You have to use your muscles more than you normally would. There's decreased gas exchange, so your oxygen use is reduced. Your oxygen uptake is reduced, and your ability to blow out carbon dioxide is also reduced as well too. Because you have scarring, the size of the lungs is also reduced. So you have smaller lung volumes, which means that they're less efficient. You have to breathe more frequently to get the same effect as you would if you had larger lungs. And then finally, because of where the scarring in the lungs is, it actually triggers a few receptors, and it actually increases the brain's stimulus to breathing. So basically, it makes you feel more short of breath. So because the lungs are stiffer and it takes more effort, because they're less efficient, it doesn't work with exchanging oxygen and carbon dioxide very well, because they're smaller, and because you have more air hunger or you feel more short of breath, it's not surprising that people with pulmonary fibrosis have a reduced oxygen and they're very short of breath and tired. Next, please. So this is a relatively normal CT of the chest. So your left on the screen is actually the right lung. Your right on the screen is actually the left lung. That little circle thing in the top part is actually a cross-sectional view of the heart. And so you can see a nice gray texture. There's not too much in the way of scarring. Next, please. This would be an example of an abnormal set of lungs. So what's highlighted in the red circle, there's some significant scarring. There's a bit of a grayish or whitish coloration there, which could suggest inflammation or very fine scarring. And there's a few holes there that shouldn't be there. Those are probably airways that are being pulled open. So that would be a good example of what interstitial lung disease or pulmonary fibrosis could look like. Next, please. Another example showing some significant scarring there. This is scarring that's mostly on the outside of the lungs, and there might be some inflammation as well. Next, please. And could you click one more time, please? So in the red circle, you're seeing significant, what looks like end-stage fibrosis. All those little holes there, those are actually small airways that are being pulled open. but it looks like what we describe as a honeycomb, which you could see if you think of a beehive. Next. Okay, so that's just a brief sense of what pulmonary fibrosis is. If you could imagine all that scarring taking place in your lungs, it's not surprising that they're not going to work as well, and you'll be quite short of breath if it's significant. Now, this little happy picture is a picture is a relatively simplified view of what the heart and the lungs look like. Disclosure, the heart and the lungs don't actually look like this, but it's a good comparator. So R meaning right side of the heart, L meaning left side of the heart. So if you can see, there's the blue arrow shows that the right side of the heart draws blood from the body. It holds it there and it pushes it towards the lungs, which is the blue arrow. Blue meaning that there's no oxygen in that blood, or the oxygen content is reduced in that blood. The lungs do their work to put oxygen into the blood, and then the good quality blood, big L there, and then it gets distributed to your body so that your body can utilize the good oxygenated blood. So the purpose of the right side of the heart is mainly to draw blood from the body and send it to the lungs so that it can get good oxygen. And the portion of the blood vessels that is flowing through the lungs is what we call pulmonary circulation. Pulmonary meaning lungs. Next, please. Okay, so pulmonary or lung circulation is a high volume, low pressure system, meaning that the vessels are able to accommodate and fill and take a whole bunch of blood, but under low pressures. And the right side of the heart does very well in this situation. So the right side of the heart is good at accommodating and filling up and passing the blood gently to the lungs. It works very well. That's what the right side of the heart is built to do. The left side of the heart is a lot stronger, actually, and it's a lot thicker, and that's what pumps that blood through the body to give you your normal blood pressure. Now, if you get increased pressure in the blood vessels going through the lungs, if you get stiffening or thickening of the pulmonary vessels, then the right side of the heart has to work harder. As the right side of the heart starts to work harder, it starts to open up and dilate. And sometimes over time, it can get a bit thicker because the muscle is trying to get stronger so it can still do what it's supposed to do. But that adaptation is not good. And in the end of the day, the right side of the heart will only be able to do that for so long. Then it will start to lead to right ventricular failure or right side of the heart failure. Now, pulmonary arterial hypertension, or PAH or PH, is elevated pressure in the blood vessels within the lungs. And the biggest issue here is that the right side of the heart has to work harder than it should. With increased stress, you could have progressive damage and potentially decompensation on the right side of the heart. Next, please. And this is just another picture of what's more anatomically correct, showing the circulation between the heart and the lungs. You can click one more time, Mary Ellen, please. And what's circled there, so with pulmonary hypertension, the vessels in the lungs, the pulmonary circulation is stiffer and narrow. And the lower red circle is basically the right side of the heart stretching and swelling and getting a bit thicker because it has to work harder than it's supposed to. Next, please. Okay, so I'm just closing the chat box. Okay, so this is a case, not the real name of the patient, of course, but it is a real story. Let's call her Miss Edwards. So she's a 69-year-old female presenting with shortness of breath over 1 year. She was mainly limited by pains in her legs, so as a result, she wasn't very active. In retrospect, she noticed some thickening in her hands with the skin, and her fingers actually turned very white when she reached into the cold freezer or went out in the wintertime. This might sound very familiar to some of you. Now, recently, she actually noticed some ulceration in her fingers. Some of them were actually open and looked infected. She also had some heartburn or acid reflux, and along with that had a mild persistent cough. Previous medical history, she wasn't diagnosed with a whole lot. She was treated for blood pressure, treated with cholesterol. She's never smoked, and she used to work in an office, but she's not working anymore. Next slide, please. So when we saw her, her oxygen saturation was 92%. Now, normal oxygen saturation would probably be above 95%. So although not severe, it is reduced. The patient wasn't very distressed. She was fairly comfortable with that oxygen level. Heart exam was okay. Lung exam, she did have these crackles at the bases. And it's just simply that. It sounds like Velcro. It sounds like Rice Krispies, crackles at the bases. When you look at her hands, she had some tightening of the skin. So you couldn't really pinch the skin. You couldn't really pull off the skin off the finger there. And she had several shallow ulcers noted on several of the fingers. She also had a bit of swelling, which we thought was fluid in her legs. Next, please. This is an example of her chest X-ray. It's a little bit cloudy there, but it's not a normal chest X-ray. If you click next again, please. So the red circle basically highlights that the bases of the lungs are not as clear. They're a little bit too white and wispy. There seems to be something going on down there. Next. Corresponding to that is her CT of the chest, and you can click again, please. Oh, yeah, when you look at the cross-sectional views, you can see that there doesn't seem to be completely normal lungs. There are some areas which look like, and maybe some scarring as well too. Next, please. And those are highlighted in the circles. So the red circle would probably be an area of scarring versus the blue circle, which looks like relatively normal lungs. Next. Next. And then at the very bottom parts of the lungs, as I've highlighted there, that's a fairly abnormal area of lung. What that represents are some dilated airways. Those are those little black circles you're seeing. There might be some background scarring and inflammation. So that's a significantly abnormal section of her lungs. Next, please. So another very important test that we use is something called a pulmonary function test. And this is basically a test to determine how well the heart is, how well the lungs are doing their job. How much volume is there, how much air you can push out quickly, and how well the lungs are able to take up oxygen and blow out carbon dioxide. So in the first part, which is called spirometry, that's your flows, that's your ability to blow your air in and out. And what's circled at the top there is the forced vital capacity. So that's 56% out of 100. So pretty reduced. So her volumes are smaller than they should be. Likewise, the next paragraph, there are lung volumes. So the TLC, or the total lung capacity, is only 59% out of approximately 100. Also small. And then finally at the bottom part, her diffusion, her measure of the ability to take up oxygen and blow out carbon dioxide, is very low. That's 31%, normal being about 60 or 70%. So basically this pulmonary function test suggests that this lady's lung volumes are small and they're not able to take up oxygen and blow out carbon dioxide very well. Next, please. So then this patient, Miss Edwards, had an echocardiogram, which is a heart ultrasound. So this is basically the equivalent of the pulmonary function test for the heart. It tells us how well the heart is doing its job, how well that pump is working. So when she had the test done when we first met her, her left side of the heart was functioning very well. That's also called the left ventricle. The right side of the heart, remember, that's the side that gets compromised if you have pulmonary hypertension, is also functioning fairly well. So that's called the right ventricle. But when they did check the pressures on the right side with the ultrasound of the heart, the pressure was a little bit higher than it should be. Next, please. So then, because she was here, she was actually from a fairly called a cardiac catheterization, or what we call in Newfoundland as a dye test. So this is a direct measure of the pressure on the right side of the heart. And this would be the confirmation test for pulmonary hypertension. So the ultrasound of the heart is the screening test to raise the suspicion of pulmonary hypertension, but the dye test, or the cardiac cath, is what confirms it. And when they did this test, they did find that her pressures were slightly above normal. Next, please. Okay, so this patient saw a rheumatologist who felt that she met the criteria for systemic sclerosis or scleroderma. Based on the imaging and based on the pulmonary function test, we also felt that she had interstitial lung disease, which is a broader category for pulmonary fibrosis. That's the official medical term for pulmonary fibrosis. And we felt this was most likely scleroderma associated with the pattern which is referred to non-specific interstitial pneumonia, or NSIP. The pattern name is not that important, but this would be the most typical pattern you would see in scleroderma-associated interstitial lung disease. Based on the degree of reduction in lung volumes and based on how she was doing, we felt that we should treat her. And we chose to treat her with an immunosuppressant, so something to reduce the inflammation in the body called mycophenolate mofetil, or Celcept. With the borderline pulmonary hypertension, so remember that that dye test suggested that the pressures were up a bit. We thought, okay, you know what, maybe this is important, let's watch her closely. And she was going to get an ultrasound of the heart every few months to make sure that the pressure was kept in check. Next slide, please. In terms of her interstitial lung disease, when we saw her over the subsequent years, she did have a slow decline. The volumes got smaller and smaller, despite keeping her on this medication. We pushed up that dose of medication as high as we could go. She was on a little bit of prednisone as well, too. But eventually she did require oxygen therapy at home. In terms of the pulmonary hypertension, this did become very obvious subsequently. And over the 2 years, her pressures went up considerably. So she was followed by my colleague in the pulmonary hypertension clinic, and she was started on escalating therapy. Next, please. Okay, so scleroderma-associated interstitial lung disease. Now, this is actually fairly common. Interstitial lung disease in general is rare. Scleroderma is also fairly rare, but within scleroderma, once you've established the diagnosis of this, interstitial lung disease, or ILD, is 40 to 75% will have pulmonary function abnormalities. That might not be severe, but it could be clinically significant. And it could certainly affect mortality over the long term. It's more often seen in those people that have sclerosis diffusely, so not just below the elbows, but a bit more proximal, around the face, around the legs. So the greater the skin involvement, the greater the risk of the lung disease. The cause of the interstitial lung disease, it's a little bit uncertain, but there's lots of inflammatory and pro-scarring mediators. So there's all these things circulating around in your blood for the same reason that they cause scarring and inflammation in your skin and other organs. They can cause scarring and inflammation in your lungs. Over time, this leads to an accumulation of stuff in your lungs, which leads to scarring over time. And there's usually not a ton of inflammation here. This is primarily a scarring process. The other important thing is, unlike when you cut yourself and it scars over nicely to protect you, the scarring in your lungs and the scarring in systemic sclerosis is unregulated. So it's inappropriate, and sometimes it can continue to progress despite therapy and doing everything you can. Next, please. So with scleroderma ILD, typically it's a pretty subtle onset. The symptoms are very nonspecific. So usually the first thing that individuals will notice is if they start to feel short of breath with the activities that they used to do fairly comfortably. They may develop a dry, non-productive cough, meaning they're not coughing up a lot of phlegm or mucus. And with ILD in general, typically the cough is pretty dry. It's more of like a barky, variable trajectory. So some people do fairly well. They don't have much change over time. And there are people in my clinic I've been following who have had this for more than 10 years, and we've never really had to treat them. But some people can have more aggressive and severe disease, which declines quickly. And what's interesting is that more severe disease, so people that are not going to do well with this lung disease long term, it's usually more obvious within the first 2 years of diagnosis. So that initial period is fairly critical to monitor. Next, please. So there's some great questions coming through. We'll try to save those and answer those towards the end. But to answer one quickly, absolutely, you guys can have the slides at the end of this. So in terms of ILD treatment, the interesting thing about ILD is that certain types of ILD need to be treated regardless. Other types of ILD we can watch and wait. So with close monitoring, with a good relationship with your healthcare provider, we could just watch this. We could do pulmonary function testing periodically. We may have to do a CT scan every now and then. And usually we follow individuals more closely in the first few years. As time goes on, we might space those out a bit more. And there are some people I see once a year. There are some people I see every 2 to 3 months. If someone has more advanced disease on onset and they're very symptomatic, you probably are concerned that they'd lose any more lung function, they'd be in big trouble. So we're more likely to start treatment early in those individuals. And certainly if you have progressive disease, so if you're one of those people that have disease that's clearly marching downwards within those first 2 years of diagnosis, with worsening lung function, worsening imaging, increased shortness of breath, then certainly that warrants treatment. Next. So in terms of the types of treatment, I don't want to spend too much time on these, but certainly one of the types of drugs that we've used for years is immunosuppression. So medications to reduce your immune system, with the theory that with scleroderma, your body's immune system is part of the reason why and inflammation. There's several different agents that have been tried, and depending on physician comfort, we might use one over the other. But the ones listed are usually the more common ones in systemic sclerosis ILD. So cyclophosphamide, an old immunosuppressant, fairly potent. Mycophenolate mofetil, which we used with our case or trademarked as Celcept. Azathioprine or Imuran, which is often used in other types of rheumatic disease as well. And there are a few others depending on how severe the disease is. You may use some steroids along with that, with caution, because higher doses of steroids is not usually tolerated very well in scleroderma. Data here to support the use of these type of drugs. There is a small but significant improvement in lung capacity. So this is one big trial called the Scleroderma Lung Study 2. And this was comparing cyclophosphamide, which is the previously accepted drug of this type of lung disease, to mycophenolate mofetil or Celcept. And as you can see, the red and the blue lines are going up a little bit, although they dip a little bit at the end. But if you do look at the legend on the left-hand side, you're seeing that these numbers are pretty small. We're talking about maybe a 2 or 3% improvement in your vital capacity. So I think the emphasis here is that the primary purpose of this treatment is to stabilize the disease. If we get an improvement in lung function, that's fantastic. But usually the improvement in lung function is fairly modest. And the main purpose of treating this type of lung disease is to try to prevent things from getting any worse. Next, please. So more recently, we've started to use what's called antifibrotic therapy or antifibrotic treatment in this type of lung disease. And this is with the theory, of course, that the primary issue in systemic sclerosis is scarring. So a drug called nintedanib, which is marketed as Ofev, is the first formally approved drug to treat this disease. And technically, the other drugs that we just talked about are off-label. They don't actually have a true indication for this disease, although they do have evidence. This is the only drug that's actually approved formally for systemic sclerosis ILD. The chart short is shifted a bit low there, but this drug has been shown to show about a 50% reduction in the rate of lung function loss over time. So in summary, the main purpose of treating ILD and systemic sclerosis is on stabilizing the disease. If we have an improvement, that's an added bonus, which is wonderful. Treatment is not warranted in everyone, so we don't need to treat everyone. And this is important because these drugs do have side effects. So if we know that this disease has been stable for 5 or 10 years, if the disease is milder, then we might choose to watch things, all with the focus on quality of life. In terms of drug coverage, so immunosuppressants is variable based on which region in the country you live and based on which drug you choose. Nintedanib, that antifibrotic drug, is Health Canada approved, so it's accessible in this country. Right now, it's mainly restricted to private insurances. And as far as I know, based on my discussion with one of the reps a couple of days ago, it's not approved formally in any Canadian province yet by the provincial payer. It's certainly not approved in Newfoundland or any of the other Atlantic provinces. But hopefully soon. Next, please. Okay, so now we're going to talk about systemic sclerosis associated pulmonary hypertension. As a review, this is elevated pressure and resistance in the lung circulation, meaning that the right side of the heart has to pump harder than it should. Pulmonary circulation is the blood vessels that are floating through the lungs. So, you know, some studies suggest that the pressures on the right side of the heart can be increased in up to 30% of patients with scleroderma, which is then subsequently confirmed in about 8 to 12% of patients on cardiac catheterization. So although the majority of people don't develop pulmonary hypertension, you know, 8 to 12% is significant enough that we need to keep a very close eye. So risk factors to this include long-standing scleroderma. The longer the disease, the more likely you are to develop this. The older age at the onset of scleroderma, if you have severe Raynaud's, if you have advanced diffusion impairment, so that measure of oxygen and carbon dioxide exchange is really low, and then certain blood markers or serology would increase one's risk for pulmonary hypertension. Next, please. Symptoms, once again, just like ILD, it's fairly non-specific. So you can get some shortness of breath, you can get limitation in exercise, you can get some fluid retention in your legs, which is usually a later symptom. And likewise, at later stages of the disease, you could get dizziness with activity. So sometimes some people with advanced pulmonary hypertension will feel that when they get up and move around, they feel faint. But in the earlier stages, it's shortness of breath, exercise limitation. You can kind of see why this could be missed in the first few months or even years. Once pulmonary hypertension is established in systemic sclerosis, without treatment, it is typically progressive. It typically gets worse. Next, please. So the diagnosis of this, an echocardiogram is non-invasive. You have a lot of great information. It can show how the heart is functioning and give you an estimate of the pressures on the right. A 6-minute walk test, or a 6MWT, is a validated endurance test. For any of you that have done this already, you know exactly what I'm talking about. But very simply put, a length of the hallway is measured out, and we get someone to walk back and forth for at as brisk a pace as they can for 6 minutes to determine how far they can walk. It helps to monitor function over time, and it's a very useful test in the setting of pulmonary hypertension because it is predictive of outcomes. So the lower your walk distance is, typically the worse your outcomes are. Maybe more importantly, it's helpful to monitor things over time. So if I bring you into clinic one day and your walk distance is, 400 meters, the next time around it's 350 meters, that could be significant. And then a cardiac catheterization, or that dye test we talked about in the case, is a direct measure of the pressures of the heart. So they pass a transducer in through the groin or the wrist and check the right side of the heart. It is the gold standard for the diagnosis of pulmonary hypertension, and this is what you want to use to confirm the diagnosis. You can also evaluate the left side of the heart, which is sometimes done concurrently to look for the blockages that people typically develop when they have coronary disease or ischemic heart disease. Next, please. So medical management, one of the big things about pulmonary hypertension is you don't want to have too much fluid on board. With the right side of the heart not doing so well, because the right side of the heart draws blood from the body, if it starts to decompensate, you start to get blood and fluid building up in the periphery in the legs. And it's really important to keep that fluid status at bay. So if the fluid is too much on the body, the right heart has to actually work harder. So often people with pulmonary hypertension are treated with fluid pills or diuretics to prevent this. And while this is happening, we have to monitor the weight and kidney function to make sure that that fluid pill is not drying the body out too much. In terms of pulmonary hypertension specific medication, there are several medications for this. These are called pulmonary vasodilators. Basically, we're trying to get those vessels in the lungs to relax so that the right heart doesn't have to work so hard. There's multiple different classes. There's a few listed right there. Just like systemic blood pressure, so blood pressure in your arms or your legs, combination therapy is common, and in fact, it's encouraged. So with this type of management, it's important to review patients frequently with escalation of therapy very quickly. And data recently has shown that, you know, it's important to aggressively escalate medication. You want to get people with pulmonary hypertension as asymptomatic as possible with an escalation of medications, and outcomes tend to be a bit improved in that situation. So these patients are typically managed by respirology and cardiology. Next, please. So the presence of pulmonary hypertension in general, regardless of the underlying lung disease, whether it be COPD or interstitial lung disease, but in particular systemic sclerosis, it is predictor of poorer outcomes. So it's really important to recognize this and treat this early rather than late. Early clinical decline in scleroderma, so people that do really poorly in scleroderma, is often associated with the presence of pulmonary hypertension. The higher the pressures in the lungs, the lower the 6-minute walk test, the worse prognosis. And with the pulmonary vasodilator therapy, so those specific medications for pulmonary hypertension, there are clear improvements in your ability to get up and move around, and there is a reduction in hospitalizations as well too. And like I mentioned on the previous slide, there's strong evidence to support combination therapy, either upfront or sequentially. Once again, we're unfortunately at the mercy of the payers for drugs, and it's difficult sometimes to get approval for 2 drugs at the same time starting up front. But our pulmonary hypertension experts, to get around that, would typically start 1 drug, and if they know they're getting on a 2nd drug soon, they'll bring the patient back quickly and try to escalate therapy within a month or 2. So you try to push the therapy, you try to push the dosage, use combination therapy as side effects allow to improve your symptoms overall. Next, please. So in terms of screening and scleroderma, so with pulmonary hypertension, it's accepted that we should be doing screening ultrasounds of the heart every 1 to 2 years, and maybe more frequently, especially if pulmonary hypertension is established. Further investigations based on symptoms. So if those ultrasounds start to get a bit worse, then a patient will typically earn themselves a dye test to confirm what the pressures are like. And then in terms of evaluation after that, once pulmonary hypertension is established, we usually use the walk test, we usually use the ultrasound of the heart, and we use blood work plus or minus the dye test to monitor improvements with therapy. With interstitial lung disease, you know, most people with scleroderma should get a baseline pulmonary function test to see what things are looking like. If things are completely normal, then maybe you can repeat that every 1 to 2 years. But if the pulmonary function test is abnormal, they usually earn themselves a CT of the chest to look for pulmonary fibrosis or interstitial lung disease, and subsequently will end up making their way to a lung specialist. And, you know, within the recent few years, there's been a lot of discussion about doing a baseline CT of the chest in every person that has a diagnosis of scleroderma. This is variable in practice, but I think it's more increasingly accepted. I think in our institution, we're probably going to try to push towards this, to do a baseline CT of the chest in anyone that gets a diagnosis of systemic sclerosis, and then periodically thereafter, if the diagnosis is there. Next, please. So then what should you do as a patient or as a caregiver? Very important to stay active. And I can't stress this enough. I mean, it's good for your joints, it's good for your systemic sclerosis, it's good for your overall health. But the other thing that's really important here is that for those that are inactive, say, take my case, by the time they get symptomatic, the disease could be fairly advanced, right? So if you're going for regular walks, if you're doing a degree of aerobic activity or strength conditioning on a regular basis, then you're better able to gauge when things start to slip. Whereas if you're fairly sedentary, you're not moving a whole lot, then by the time you're short of breath, you could have pretty severe lung disease or pulmonary hypertension. So to the best of your abilities, find an activity that suits you and try to stay active and move around on a regular basis. For sure, if you have systemic sclerosis, you should talk to your doctor if you feel that your breathing is getting worse. If you're starting to have a persistent non-productive, so non-mucousy cough, and if you start to develop any fluid retention in your legs or dizziness with exertion. And then further, in terms of bread and butter stuff, it's really important to reduce further lung injury. So get your vaccinations to prevent any pneumonia or influenza. Manage acid reflux or heartburn. So there has been some evidence to show that individuals with significant acid reflux could have worsening of their lung disease, their ILD. And the theory there is that small bits of acid could dip down into the lungs and cause some inflammation. So make sure that acid reflux is managed either by lifestyle management or by medications. And don't smoke anything. Smoking cigarettes, marijuana, vaping, whatever it is, will just add further insult to injury. And especially if you have established interstitial lung disease, it's really important to avoid smoking anything. If you choose medical marijuana for whatever reason, if you could avoid the lungs and choose edibles or oils or butter, that would certainly be preferable. So try not to smoke anything for fear of making the lung injury worse. Next, please. Okay, so in summary, pulmonary disease and scleroderma is actually quite common. A lot of times the disease could be fairly mild, but it could be a significant cause of symptoms, and it is a major cause of mortality in scleroderma. Symptoms are very subtle, so it's important to monitor individuals very closely. Consider early investigations with pulmonary function testing, chest imaging, or an echocardiogram. Those are things we should be doing routinely, and certainly we should do them more frequently or urgently if symptoms are present. In terms of treatment for interstitial lung disease, it's variable. It's based on severity, evidence of worsening. Some people we choose not to treat, and that's okay if things are stable or if the risk of the drug is higher than the benefit. For pulmonary hypertension, if it's present, we almost always treat it unless there's a contraindication for whatever reason. And usually we're fairly quick to escalate therapy based on symptoms, often using a combination of medications. Okay, next please. Great, okay, so that's it. So that's the quick and dirty on pulmonary hypertension and systemic sclerosis ILD in the setting of scleroderma. I hope that was helpful. And now we can open up to questions. I'm happy to answer anything you guys might be wondering about.
Thank you, Dr. Vidyasankar, for your presentation. The information you provided is so welcome by many of us that have this condition. And the more we can learn, the better equipped we are to manage our health. So as you say, we're now going to start our question period of our webinar. We'll just repost the slides on how to access the Q&A on either your computer or your tablet. There we go. The tablet is at the top, and then with your computer, it'll be at the bottom. Okay, I'll start with the questions now. Okay, the first question is from Renee. Are there any special considerations for ILD in polymyositis, scleroderma overlap syndrome?
So that's a great question. So polymyositis is another type of autoimmune disease, which is often, which can certainly be associated with interstitial lung disease. Sometimes polymyositis ILD can be very severe and aggressive. So certainly with polymyositis and scleroderma overlap syndrome, these individuals will need to be followed more closely. And I think we would have a lower threshold to treat, especially if the disease tends to be a bit more aggressive. It's a great question.
Okay, our second question here is from Helen. It says, what about the new drug OFEV, which is the same as the other one?
Yeah. So the nintedanib, the one that I mentioned there, I mean, you know, truthfully, I think the evidence around this drug has been great over the past couple of years. There's an alternative antifibrotic drug with, although the studies haven't shown it, you know, maybe at some point that'll be approved as well. But right now, OFEV is the drug, the only antifibrotic drug that's approved for systemic sclerosis ILD. Coverage is the issue right now. Once the public payers pay for it, I suspect we're going to use this fairly frequently. I think the general consensus is you still might want to consider the immunosuppressive therapy like mycophenolate, Mofetil, but certainly I would have a very low threshold for considering combination therapy between that drug and OFEV. I've had a couple of people with private insurance, and some private insurances are picking this up. So certainly you should let your physician know that you have a private insurance, and you'd be surprised. You know, some of these insurances will start to cover this drug. But right now, we do have a limitation with the public plan because they are not supporting this. The only thing they support OFEV for right now is for idiopathic pulmonary fibrosis, which is a separate type of interstitial lung disease.
Okay, thank you. This is from Geraldine. Says, it's encouraging to hear about reduced amount of lung function lost per year with nintedanib. Is it effective for people who have already had lung deterioration? That is, do you need to take it early in your disease, or is it also as effective to reduce further loss?
So right now, the evidence which suggests that it should be a consideration for a patient despite whatever lung function they start with. So there's always a potential benefit based on what we see right now. Now, the studies included a margin of lung function. So if you fall out of that, it might be hard to get the coverage. But based on our experience with this drug with idiopathic pulmonary fibrosis, in my opinion, I would say that this drug should be considered regardless of where you start. So even if you've lost lung function, there's still a potential benefit in starting this if the side effects are felt to be tolerable.
Okay, thank you. The next one is from Zandra. Says, hi, I have not fibrosis in lungs and full capacity, but only obtaining 32% oxygen.
So
go ahead.
Go ahead. Yeah, so I guess what reason can that be? I have a little bit of pulmonary hypertension.
Yes.
So if you had a pulmonary function test and it showed that the lung volumes are okay, if your imaging showed that you don't have significant scarring, then absolutely, I think we would have to look for other possibilities here. Certainly pulmonary hypertension can cause this. I'm not clear, sorry, on the 32% oxygen, do you mean that you're getting supplemental oxygen? Or is that 32%, is that your diffusion capacity? Is that the bottom part of the pulmonary function?
Mm-hmm. Hasn't noted that.
Okay. My diffusion, okay.
My diffusion, yeah.
My diffusion. Yeah, so that's important, right? So if the scan shows that there's no significant scarring, it could certainly be related to pulmonary hypertension. The other thing too is that other things can sometimes drop that number, things like your red blood cells. So that would be important to check in with your doctor to figure out what the true etiology is. I mean, it could be related to pulmonary hypertension alone, or it could be related to some other factors.
Okay. The next one is, should you exercise if you have ILD? And if yes, what exercise is most suitable?
Excellent question. So the answer is yes. The challenge with ILD is the oxygen, right? So if there's significant interstitial lung disease, it's really important to have a bit of a formal assessment to determine if your oxygen is dipping during exercise. If you have oxygen needs at rest or your oxygen is dipping during exercise, then the safest option would be to use oxygen for exercise. But in the end of the day, you know, as long as it can be done safely, it's really important to do exercise with chronic lung disease. The ideal situation here is that you'd be able to be enrolled in something like a pulmonary rehabilitation program if you have access to it. And there you'd have someone that has good experience with this type of lung disease to coach you through things. One of the biggest things with pulmonary hypertension, ILD, and honestly, a lot of other lung diseases is the concept of pacing. So especially with ILD, you don't have a lot of reserve. It's really important to pace yourself. You don't want to get up and rush quickly because then you'll run out of steam quickly and then that'll be tough. And your oxygen might dip fairly significantly. So with monitoring of oxygen, I think most activities should be done at a paced level. Ideally, a supervised exercise program like pulmonary hypertension would be, pulmonary rehab, sorry, would be ideal. But most importantly, I think there should be an assessment to determine if your oxygen is dipping during exercise.
Okay, the next question, how close does COPD and ILD compare?
Very good question. It's often confused. The two are often confused because the symptoms are very similar, but the diagnoses are actually very different. So COPD is truly a problem with the tubes, with the airways. It's usually smoking related in our part of the world, and it's more of a difficulty getting the air in and out. And actually what's interesting is the lungs actually tend to be softer than normal in COPD, means that they're stretchier. With pulmonary fibrosis, the airways are fine. There's not a problem with the airways. What's important about that is that puffers don't work, right? So puffers don't typically work for ILD unless you have a combination of both COPD and ILD. So they're actually quite different in terms of treatment, but in terms of symptoms, they could be fairly similar. But very important to remember that ILD is scarring of the lung tissue. So it's more of a problem with the balloons versus COPD, which is more of a problem with the tubes.
Okay, the next question is, are you familiar with radiation causing ILD? And this was on oxygen and after just recently being diagnosed.
So radiation is certainly a potential culprit for causing scarring in the lungs. If that was given in the setting of cancer, then that can cause fibrosis in the lungs. Now, once the radiation is stopped, sometimes there's evolution in that scarring over a period of a few months, even up to a year. Sometimes you can have acute inflammation, and sometimes you need steroids with that as well. Typically, radiation fibrosis is not consistently progressive. So once the evolution takes place, once the scarring and the healing takes place, the scarring typically starts to stabilize. But certainly if you have a significant amount of scarring from radiation, it can cause a fair bit of symptoms.
Okay, next question is, finding it hard to regulate stationary machine? Are high numbers hard on lungs?
Are you referring to your stationary oxygen concentrator? I suspect that's what you're referring to. So it is tough, right? It is tough because every time you have to get up and move around, you might have to turn up your oxygen. It's hard to find that balance. And sometimes you have to find a middle ground. So ideally, you get enough oxygen to keep your saturations above that 90 or 92%. It can dip every now and then, that's okay, but we don't want that dipping dramatically. Theoretically, getting too much oxygen can cause damage to the lungs. So oxygen itself can be a bit of a toxin to the lungs. But at the end of the day, it's hard. If it's hard to regulate, sometimes you just have to find a middle ground. So sometimes maybe when you're resting, your oxygen will be a bit higher, and you might have to tolerate that for the sake of avoiding dipping too low when you exert yourself.
Okay, don't have any open questions. I have a question though. I want to know if you've got any information on stem cell research as it relates to the heart disease in our lungs.
Right, so it's a fascinating topic, and it's pretty amazing what some centers have done. So in Canada, I believe it's not approved as a therapy for systemic sclerosis, but it has been done in certain centers around the world, and in the US, I know they have done it before. It's obviously a very aggressive therapy, but I mean, you know, aside from the complications of stem cell transplant, because it is, you know, there's a mortality associated with that, sometimes the outcomes can actually be fairly good. So it's tough because it's still kind of a research tool. It's not a standard of care at this point. I think we still need to learn more about it, but it is definitely a very fascinating area of research. And that is something that has been shown to theoretically improve lung function or stabilize lung disease, but systemic sclerosis in general as well too, in other organs. The big thing about stem cell transplant is that it's a very complicated process, and it does carry a mortality risk in itself.
Okay, thank you. And so I do have a mild persistent cough, but I find I have a productive cough in the mornings. Could this be a result of acid reflux overnight?
Absolutely, absolutely. I think that's probably where if you have systemic sclerosis, that's probably where I would start. If the cough is mainly mucousy and phlegmy, I start to look for other things like maybe chronic nasal drainage or post-nasal drip or acid reflux. So I definitely think that from my approach, I typically try to manage those things as aggressively as possible. But if it's persistent and you do have established pulmonary fibrosis, it could be related to that. But absolutely, acid reflux overnight is a consideration, and certainly I think looking into that is important.
Okay, thank you. Next one is, if I wanted to come to your clinic for a diagnosis because of some symptoms, can I book an appointment, or do I need to get a referral from my physician?
Great question. So right now it would still be a referral-based thing. It was referral-based assessment. If you live in my region, certainly I'm happy to be of assistance, but it does need to be through another healthcare provider.
Okay, thank you. Another question, but this person said I was denied stem cell transplantation due to my PAH. Said that the outcome would not be good.
That's very interesting. Yeah. Okay, that's important.
The next one is from Marcia. Is OFEV as effective once a day if it can't be tolerated twice a day?
Good question. So I don't know if we have a lot of evidence for that in systemic sclerosis, ILD specifically. We do know that in idiopathic pulmonary fibrosis, which was first the disease approved for this drug, at the lower dose, which is 100 milligrams twice a day, there's still some benefit. It's not as good as the 150 twice a day, but there's probably some benefit. I guess if you think about the science behind it, there's probably an argument to say that once a day is better than nothing. It's probably not as good as twice a day, but absolutely sometimes we have to accept that for the sake of tolerance of the side effects.
Thank you. Would you recommend diagnose patients over 65 with systemic sclerosis to receive the COVID-19 vaccine?
So I think in general, this patient population, so people with systemic sclerosis shouldn't be excluded. People with chronic lung disease theoretically could have worse outcomes from COVID-19. There's some uncertainty as to what the outcomes will be if someone is on immunosuppressive drugs. But in general, I personally, from my perspective, I think that people with systemic sclerosis above the age of 60, over the age of 65, if there are no contraindications, should be considered for the vaccine.
Okay, thank you. Just running short on time here. Just got time for a couple more. Can we be provided with the questions and the answers from today's webinar? Is that possible?
Of course, it's great for me.
Yeah. Okay, well, one more question. What are the potential
symptom anyways? So that is sometimes a bit of a concern. But the majority of people from our previous experience with nintedanib that are on the drug have fairly mild diarrhea. So they might notice that they may go to the bathroom once more in the day, or their stool is a bit looser. Very rarely, less than 1 or 2%, the diarrhea can be severe, and that needs to be monitored. And the drug typically is stopped at that point. It can also potentially cause a mild inflammation of your liver enzymes. That's probably less than 5%. So we do typically monitor liver enzymes on a regular basis. For the most part, it's a fairly well-tolerated drug. But if I've had to stop it, it's typically for diarrhea.
Okay, thank you. Okay, folks, that's the end of our question period for today. Okay, we want to thank everyone for attending. And this webinar was supported by the Government of Canada's Emergency Community Support Fund and Community Foundation of Nova Scotia. Thank you, Dr. Vidyasankar. We really appreciate your time today and all the information you've given us, answers to all our questions. It's really been wonderful. I'm sure everybody's really thankful for it. A recording of our webinar will be posted on Facebook and YouTube. Okay.
Wonderful. Thank you for inviting me. I was more than happy to join, and all of you stay safe.
Okay, thank you. In closing, a reminder to purchase your 50/50 tickets for our winter raffle box draw if you have not already done so. Ticket sales will support Scleroderma Atlantic's David Shea Memorial Patient Support Fund, which financially helps those living with scleroderma in Atlantic Canada. The draw will take place on Rare Disease Day, February the 28th. Find the link to the raffle on Scleroderma Atlantic's Facebook page. Okay, our next webinar is going to be Sunday, March the 21st. It's our gastro challenges with scleroderma, gut reaction top to bottom. Join us for the Zoom meeting on March 21st, Sunday at 2 p.m. Atlantic Standard Time. Thank you, everyone.